Hi, everyone. We're going to get started. My name is Yuki Kimura. I'm the Division Chief of Pediatric Rheumatology at Hackensack Meridian Health and the Joseph Sanzari Children's Hospital. And it's my pleasure to introduce the speakers. Today, we have three speakers speaking to the topic of the burden of group-based Streptococcus and its complications. First up, we're going to have Dr. Sejal Bafsar, who is a pediatric infectious disease specialist at Joseph Sanzari Children's Hospital and an associate professor at Hackensack Meridian School of Medicine. She did her pediatric residency at NYU and her pediatric infectious disease fellowship at Mount Sinai in New York City. And she serves as the Director of Pediatric Antimicrobial Stewardship Program at our Children's Hospital. Her clinical interests include travel medicine and infections in immunocompromised hosts. Then we will have hear from Dr. Monica Chug, who is an attending in the Division of Pediatric Cardiology and recently joined our Children's Hospital in April of 2024. She did her pediatric residency at NYU Langone, her cardiology fellowship at Mount Sinai. She followed along Dr. Bafsar's tracks and was a faculty member at Robert Wood Johnson prior to joining us at Hackensack. And then last but not least, we have Dr. Jennifer Weiss, who's a pediatric rheumatologist at the Joseph Sanzari Children's Hospital and an associate professor at our medical school. She did her pediatric residency training and rheumatology fellowship at Schneider Children's Hospital in Long Island. And she is currently the associate director of pediatric rheumatology here and is active in clinical research and quality improvement through CARA and PR Coin. So Dr. Bafsar, please take it away.
Don't forget to unmute Dr. Bafsar.
Sorry about that. So I'm going to start off our talk just giving a brief overview of group A strep infections. Before I start, just wanted to say that all three of us don't have any disclosures. We have no financial interest or anything in this. In terms of objectives, the first one is that we want to help you guys plan the appropriate diagnostic evaluation for a patient suspected of having group A streptococci infection or post-infections complications, recognize the features of invasive group A strep infections, and then lastly, plan appropriate management for patients with different manifestations of group A strep infection. So in terms of an overview, there's two different types of clinical manifestations. The first is the suppurative ones. So those are the ones that you think like have an acute strep infection. So when you look at those patients, there's non-invasive, which includes those that you probably see most commonly, which is pharyngitis and skin infections. And then there's invasive infections, which include streptococcal toxic shock syndrome and acute necrotizing fasciitis. And then in terms of the non-suppurative complications, which include acute rheumatic fever, which you'll be hearing a little more about later in the talk, post-streptococcal reactive arthritis, post-streptococcal glomerulonephritis, and then pediatric autoimmune neuropsychiatric disorder associated with group A strep, which is abbreviated with PANDAS. So a little bit about group A streptococcal pharyngitis. So this is the most common clinical manifestation that pediatricians will see. You're going to suspect this in anyone who has a sore throat and you notice that they have tonsillar inflammation, cervical adenopathy, petechiae in their palate, strawberry tongue, or also complaining of abdominal pain. And this can also occur with the rash that people sometimes get, which is referred to as scarlet fever. Group A strep pharyngitis overall is uncommon in children younger than 3. In terms of testing, so I know we get a lot of referrals for recurrent or repeated positive strep tests. But there's two different types of tests. So there's rapid tests, which look for the group A strep antigen. Those have high specificity, but sensitivity ranges from 75 to 85%. So when you have a negative rapid test and you do suspect that the patient may have group A strep, you are supposed to send a confirmatory culture, and you can always have growth on there, and then you would know that the patient has it. So that's supposed to help pick up in terms of the lack of sensitivity that a rapid strep test might have. Throat cultures, however, cannot differentiate someone who has acute infection at this time versus those that are considered carriers. But there is less than 10% false negative. So if you have a negative throat culture, the likelihood of you actually having strep pharyngitis is actually pretty minimal. Right now, actually, we've been having a lot of patients referred to our office recently. Um, who are just having repeated positive rapid streps in their pediatrician's offices, and we're not really sure why. But there was a study that really looked into patients who were treated for group A strep infections, and if they had rapid testing done in that 28 days like after being treated. And there is in that study they did note that they had 11% of patients who, if they had strep within the previous 28 days, their rapid test was still positive. I don't know, like, if anybody really knows the exact number of days. It's very patient dependent, but often when we see these patients and we go through their clinical histories to see like the timeline of their infections, if they don't have a positive culture to go with that rapid strep, sometimes if the infections occur within the same month, we don't actually include those two infections as two infections. We kind of tell the parents, that second infection that occurred 2 weeks later may have actually been a false positive. So it's something that I've been encouraging families who have had recurrent infections to do, is to have their pediatrician send the rapid test and a throat culture to really see if there's an active infection or not. Um, then, in terms of testing asymptomatic contacts, so this includes household contacts or school contacts, that is generally not recommended. So you're really only supposed to be testing patients who actually have symptoms of strep. And then post-treatment throat cultures are only indicated for those who are at high risk of acute rheumatic fever. And per the Red Book in the United States, that really is people who've had acute rheumatic fever before. It doesn't really mean like anybody else in the United States, but in other countries where it's more endemic, it may be done more often. And so this table is treatment. I took this straight from the newest Red Book. The amoxicillin I have starred because that is probably the most common antibiotic that general pediatricians prescribe, but I just wanted everyone to be aware of the new dosing, because it is now recommended to give 50 mg per kg once daily, which I feel like most pediatricians may not be aware of the once daily dosing, but that was really done more for I guess, adherence for the patient. So if parents have difficult time giving the amoxicillin to their child, at least they only have to do it once a day instead of twice a day. So this is relatively new in the Red Book. But penicillin, amoxicillin, and IM penicillin G are the drugs of choice. I did want to spend a little time going over what to do if your patient has a penicillin allergy. So if it's a non-anaphylactic allergy to penicillin, Keflax, so cephalexin, is actually supposed to be the next in line to give the patient. And if the patient does have an anaphylactic or type 1 hypersensitivity to penicillin, then clindamycin would be the recommended. But azithromycin is listed in the Red Book as a treatment, but that really should be like a second line treatment, and you should be giving those other antibiotics instead. In terms of the chronic carrier state, so antibiotic therapy is not routinely indicated if you have a group A strep carrier that is asymptomatic. There are specific situations which you might want to treat the patient, and that would include if there's a local outbreak of acute rheumatic fever, the glomerulonephritis that happens post Streptococcus infection, and then the invasive group A strep disease. But this is something that you would want to work with the Department of Health in your area to kind of figure out if there was an outbreak. If there's a family history of acute rheumatic fever and your patient may be at higher risk for it, then that's a patient you may want to consider treating. We sometimes treat patients who are coming to see us because they've had multiple episodes of documented infections within a family, and it kind of seems like they're ping-ponging back and forth to each other. We sometimes treat then. And we often are referred patients who are considering tonsillectomy because of frequent group A strep infections. And in those patients, we would sometimes um, consider treating for a carrier infection just to see if that kind of spreads out their infections from happening or kind of eliminates the carrier state, in which case they may not need the tonsillectomy. When patients come and we're trying to treat a carrier state, I usually recommend clindamycin. It's my personal first line. And then if that doesn't work, I sometimes give penicillin and rifampin, which with that you give 10 days of penicillin and then 4 days of rifampin towards the end of the course. Um, Sometimes you can give augmentin, but really, like, I like to try at least 2 out of 3 of these regimens to really see if it's going to help before I kind of tell a family, like, okay, like maybe your child is going to need that tonsillectomy. And then for skin manifestations, so some of the more common things that you would see are going to be non-bullous impetigo or erysipelas. A lot of these infections now, it's kind of hard to tell if they are being caused by Staph aureus or group A strep. So the treatment is almost to cover both because you don't really know unless you get cultures. So if you have localized lesions, you can treat topically with mupirocin. The recommendation is to just do 5 days. But if you have extensive infections, if you give an Caflex to the patient, that would actually treat group A strep and also MSSA. So you can give a 5-day course of that. And if you do have a concern that the patient might have methicillin resistant Staph aureus, then clindamycin or Bactrim would be recommended in those cases. I'm going to spend a little bit of time going over invasive group A strep infections. I think 2, 3 years ago, after the pandemic, we started seeing a lot more patients that had this. So I just wanted people to be more aware of what to look out for. So invasive infection is when you isolate group A strep from a typically sterile site, which includes blood, joint fluid, or CSF, cerebrospinal fluid. This includes patients who have streptococcal toxic shock syndrome and also type 2 acute necrotizing fasciitis. This is a graph that I got from the CDC website, and it just shows over time the rates of invasive group A strep infection. So you can see like it's kind of trending upward since after 2020. This gray zone, they don't really have exact numbers, but what they do report on their website is that in 2022 it was probably the highest rates that they had in almost 20 years. So we don't have like the latest numbers, but it is thought to have been on the rise after the pandemic. The blue line is really showing age 65 or older, so they are most at risk for this, but the overall line is the green line. And so we are seeing kids that are having invasive infection as well. The definition of the toxic shock syndrome is from the 2010 CDC definition still, so nothing really has changed. But you have to isolate group A strep from a normal sterile site or from a non-sterile site, which includes throat, sputum, vaginal swabs, open surgical wounds, or superficial skin lesions. Along with isolating group A strep, you do have to have other signs of clinical severity. So that includes hypotension, which is obviously going to vary by age. And along with the hypertension, you have to have 2 or more of the following signs of multi-organ involvement, which could be renal impairments, coagulopathy, hepatic involvement, acute respiratory distress syndrome, anyone who has a generalized erythematous macular rash. Usually these patients look like tomatoes, and the redness starts in their face and then it starts spreading throughout their body. Like, these are patients you may be concerned about and would refer them to the ED. And anyone who has soft tissue necrosis, you'd be concerned about necrotizing fasciitis or myositis. So hypotension plus 2 of these things or more with isolation of group A strep is the definition of strep toxic shock syndrome. For type 2 acute necrotizing fasciitis, so that's when you have rapidly progressing deep tissue infection that's caused by group A strep alone or in combination with other bacterium. This is a rare infection and it usually occurs after a patient's had surgery or trauma. Basically, the symptoms are profound pain, swelling, and erythema in an extremity, and it rapidly worsens within 24 to 48 hours to the point where they may end up getting skin necrosis or decreased sensation in the affected limb. Um, for this, imaging studies like CT scans and MRI can really aid in the diagnosis, and you should get a surgical consultation right away, not only for debridement purposes, but also to obtain culture. So it's diagnostically helpful as well. For these invasive group-A strep infections, we usually start off with broad spectrum antimicrobials because we're not really sure right away that this is group-A strep. So when we're not really sure if we're dealing with a staph infection or a strep infection, sometimes we kind of cover them for both while we're waiting. But if we're pretty certain this is a group-A strep infection, you definitely want to have a cell wall inhibitor antibiotic on board, so some kind of penicillin, and also a protein synthesis inhibitor, which the antibiotics that we currently have available that do that are clindamycin or linezolid. Um, of note, there is up to 29% of potential resistance for clindamycin now. This is a relatively newer thing since I think 2020, 2021 is when the CDC started reporting this. So you never want to use clindamycin alone if you're suspecting somebody has invasive disease. If they don't have invasive disease, it's okay to try clindamycin, but definitely like you don't want to use it as the only antibiotic in someone who is very sick. This is just a graph that shows the actual clindamycin resistance over the years. So you could see that there's definitely an upward trend up to 2020. So this is definitely alarming because it's relatively new and we are seeing more of it. So just anyone who works in ICUs, you just want to make sure that you have some cidal agent as well as the protein synthesis inhibitors on board. So a lot of times, sometimes we start linezolid because we just want to be sure. But this is just important to keep in mind. In terms of prognosis, so despite aggressive treatment, the mortality rate is very high in these patients that have invasive infection. It actually ranges from 30 to 70% in those who have the toxic shock syndrome, and 11 to 22% in patients with necrotizing fasciitis. Luckily, the mortality rates are a lot lower in children compared to older adults, but we have had patients who have not survived these infections in the past couple years. And there are complications that you can get from the organ failure that occurs. And so patients may end up actually losing their limbs or having like long-term organ impairment because of these infections. So it's just something you want to catch early, send them into the hospital as soon as you suspect it, so we can start treatment aggressively up front. Okay, these are some of my references in case anybody wants to look into them. A lot of this was taken directly from the newest edition of the Red Book. And now I'm going to switch slides so that Dr. Chug can talk to you a little bit about acute rheumatic fever.
Great. Good afternoon, everyone. Can everyone hear me okay? Yes. My name is Monica Chug. I'm with the Department of Pediatric Cardiology here at Hackensack, and I'm going to be talking about acute rheumatic fever. So as Sejal alluded to, acute rheumatic fever is a non-suppurative or an immune-mediated response after an infection with a group A strep. It's an acute inflammatory illness. So when we talk about what acute rheumatic fever affects, it affects the heart, the joints, the brain, and the skin. When we talk about the acute phase of the heart manifestations, we specifically refer to it as rheumatic carditis, as opposed to rheumatic heart disease, which is the chronic valvular disease that results from either a single severe episode of acute rheumatic fever or recurrent episodes of acute rheumatic fever. Acute rheumatic fever is the leading cause of acquired heart disease in pediatrics worldwide. It's completely preventable and manageable, which is why it's so important for early recognition. In developed countries, it is nearly eradicated at this point with improved access to care, improved living conditions, and public health initiatives. However, in underdeveloped areas, the incidence of acute rheumatic fever is still significant. Typically, when we talk about acute rheumatic fever, everyone thinks about the high rates, especially in the sub-Saharan African regions, the Central and Southeast Asian regions, Middle East, Latin America, but also not to forget areas of Pacific Islands and areas in Australia and New Zealand as well. Typically, it affects children of the age group of 5 to 15 years, so just mirroring those who are affected by group A strep. Um, and after an untreated group A strep infection, there is a 3% risk of having acute rheumatic fever. However, the recurrence risk of acute rheumatic fever once you've had an episode goes up to over 50% with an untreated group A strep infection, so a significant burden. Up to 60% of these cases in endemic communities do end up subsequently developing rheumatic heart disease, which is difficult to treat once it does get to that phase. Typically, when we think about it worldwide, it is typically due to recurrent acute rheumatic fever episodes, so leading to cumulative valvar damage, which just goes to show how important secondary prophylaxis is, which we'll talk about in a little. So it's an autoimmune reaction, typically occurring 2 to 4 weeks after a group A strep infection, and specifically it's infection with a rheumatogenic strain of group A strep. So specifically the M protein on the cell wall, we develop antibodies against it, and these cross-react with tissues in the heart, the joints, the basal ganglia, and the skin, and that's what's leading to the acute autoimmune response. In terms of diagnosis, we use the Jones criteria. It was most recently revised in 2015. So this is a paper we use published in the AHA Scientific Statement, which is also endorsed by the World Heart Federation. The revision in 2015 really just takes into account the high risk and the low risk populations. And we'll talk a little bit about the differences in diagnosis. So in terms of diagnosis, so before we start, we need evidence of a preceding strep infection. Once we have evidence of that, then we look at what are, what we've all learned about our two major or one major and two minor criteria. When we talk about the major criteria, that mnemonic Jones, so J for joints, the O is heart, nodules, so the subcutaneous nodules, erythema marginatum, and Sydenham's chorea. In terms of the biggest revision in 2015, it's really dividing everybody into a high risk versus moderate, moderate and high risk population versus a low risk population. So specifically the areas in diagnosis are going to be our arthritis areas. So in our population, which is considered a low risk population, really a major criteria is going to be polyarthritis only. In areas where acute rheumatic fever is endemic, monoarthritis or polyarthritis or even polyarthralgia can be considered a major criteria. Then when we get to our minor criteria, the in terms of joint involvement for our population, the low risk population, still it's going to be polyarthralgias. But in high risk populations, we use monoarthralgias as well. Then just a little bit of a difference in the fever threshold and the ESR threshold as well. We just have a higher ESR threshold as part of our minor criteria. And then lastly, just having a prolonged perinterval on our EKG. So in terms of the presentation, so we have a preceding strep infection followed by a latent period. So during this latent period, there's a rise in ASO, a rise in anti-DNase B titers. And during this time, typically patients who are affected will have, nonspecific easy fatigability, malaise, pallor. And then somewhere at around the 2 to 4, 5 week period, they'll have these other acute manifestations. Polyarthritis, which we'll talk about, most common major manifestation, carditis, erythema marginatum, the subcutaneous nodules, and then later at about, anywhere from 8 weeks to 6 months, that's when we'll typically see the findings of chorea. So polyarthritis is the most common major manifestation, so most sensitive and least specific. In our high-risk populations, like I said, monoarthritis and polyarthralgias could be manifestations. It's important in our population, though, that's low risk. If we see monoarthritis, it's more likely to be a septic joint than acute rheumatic fever. So things that are more common, we still have to work up. The polyarthritis is typically migratory and is affecting the large joints. So usually we'll see the knees, ankles, wrists, elbows, might not be all at once. So it might be presenting in a migratory fashion. And what is interesting is that the pain is typically greater than the objective finding. So the joint might not be as erythematous or as swollen as we'd expect it, but the pain is typically severe. Reassuringly, though, it does typically respond quite well to aspirin and NSAIDs, and usually we'll see response in the joint manifestations with good coverage in about 2 to 3 days. And usually everything typically resolves in a couple of weeks. Usually there's no sequelae from the polyarthritis manifestation, with the exception of when the metacarpophalangeal joints in the hands are affected, so Charcot arthritis, which we also see with lupus as well. So carditis. So it is actually acute rheumatic fever. We do actually see a pancarditis. Valvulitis is the most common thing that we think about. So when we talk about valvulitis, so inflammation of the valve, most of the cases are going to have mitral regurgitation. Then we also have, in some cases, mitral and aortic involvement, and rarely we'll see aortic involvement alone. Typically, for some reason, the right-sided valves are typically not affected. So usually we don't see too much involvement with the tricuspid and the pulmonic valve unless they have a congenital valvar anomaly, which makes them more susceptible to having these manifestations. Um, when we say it's a pancarditis, so on pathology, if you biopsy the myocardium, you do actually see myocardial disarray, which is interesting because typically you don't have any heart failure unless it's from the valve damage. And then you can also get a pericarditis picture, so you can present with a significant pericardial effusion and pericardial inflammation. Um, if this goes untreated or is not treated appropriately, then this can recur and evolve, and when that happens, that's when we get the manifestation of chronic rheumatic heart disease. So usually that'll happen if your carditis episode on presentation is quite severe, so severe enough that the valve is so edematous that you present in heart failure, or if you have multiple recurrent acute rheumatic fever episodes. Typically, if we have a mild carditis picture without any acute rheumatic fever recurrence and good treatment and good secondary prophylaxis, then typically this is likely to resolve and not evolve into a chronic rheumatic heart disease picture. Our next manifestation, erythema marginatum. So that's seen in only about 5%, maybe 10% on papers, in some data reports. What's interesting about this rash, so it's evanescent, so it comes and goes. It's typically macular, sometimes maculopapular, not itchy. It has these sort of serpiginous borders, so these sort of circular serpiginous borders. Usually it's on the trunk going out to the proximal limbs, and it spreads out in a circular pattern, and heat accentuates the appearance of this rash. The subcutaneous nodules, not as commonly seen, so less than 5%. Usually we'll see this on the extensor surfaces of bony prominence or any extensor joints, so the spine, back of the neck, back of the elbows. These deposits are mobile, they're painless, and they may last for weeks. Synonyms chorea, so that affects about 15 to 30% of patients. This has more of a female predominance as opposed to everything else that has both equal male and female predominance. This has a longer latency period, so of about 2 to 6 months, due to autoimmune reaction at the basal ganglia. These patients will present with involuntary movements, especially of the trunk, the face, and they'll have impaired fine muscle coordination as well. So especially when doing schoolwork or handwriting, they won't be able to do so clearly, sometimes presenting with explosive speech, emotional ability, and it's definitely worse when patients are awake or under stress. So anything that's purposeful will make this worse. In terms of the minor criteria, so we talked about fever, so 38 Celsius in our low risk populations, moderate to high is 38.5. Arthralgia, so it's still polyarthralgias in our low risk population. Moderate to high can be monoarthralgia as well. Elevated ESR, CRP, and then on EKG, we'll have a first degree AV block. So that's shown here just by PR interval prolongation. So just if you're not used to looking at EKGs, that's our P wave, our QRS, our T wave, and then this space over here from atrial depolarization until ventricular depolarization. So this conduction from the atria through the AV node is prolonged. So first degree AV block. So our management goals. So first, we want to eradicate the group A strep. So usually we'll either treat with an IM dose of Pen-G, or you can do 10 days of PO penicillin or Amox. Next is going to be to control the inflammation. So either using NSAIDs, especially in our lower age group, or aspirin. In terms of the duration, so like I said, the arthritis typically responds within a couple of days, but we do continue the anti-inflammatory management until we see normalization of the inflammatory markers, which can lag. Next is going to be managing our carditis, which is going to depend on severity. So whether if they have, severe mitral regurgitation, they're going to need more diuresis. They might need some ACE inhibition. If they're really in severe heart failure that they don't doesn't need any surgical repair at that point, then they might need some inotropes or drips in the ICU. Steroids plus minus. I mean, if someone's in severe heart failure, we'll typically throw steroids at them. Now, the mild cases might not need anything in terms of carditis management, just really controlling inflammation and eradicating the group A strep. And then in terms of managing the chorea, now it used to be sort of, rest using haloperidol. Haloperidol has a lot of obvious side effects. So now I think people typically will use sort of valproic acid or carbamazepine, sometimes steroids, sometimes plasmapheresis and IVIG in severe refractory cases. Now, in terms of prevention, so definitely in the US, with improved public health conditions, less overcrowding, we've definitely seen a decrease in the presentation of acute rheumatic fever. Primary prevention, so timely treatment of group A strep infections, is obviously going to prevent this. And it's going to be interesting to see if we do ultimately get a group A strep vaccine, how that helps as well. And then secondary prevention. So that's going to prevent our long-term recurrence of group A strep infections, to reduce the recurrence of acute rheumatic fever and reduce the incidence of rheumatic heart disease as well. So in terms of our secondary prevention, we always get questions about this. So typically the best adherence is going to be with IM Pen-G. So that's going to be weight-based dosing. In our high-risk populations, usually in endemic areas, we'll try to do it every 21 days. And over here, we'll probably, in our lowest populations, usually we try to do every 28 days. If someone can't take IM Pen-G for whatever reason, then we can do oral antibiotics as well. Just, obviously you have to take it twice daily, so there's less adherence. So it's obviously we can get them into the clinic for just an injection once a month. That's ideal. And then the duration of secondary prophylaxis. So if there's any carditis with residual heart disease, meaning if there's any persistent mitral regurgitation or evolving mitral stenosis, same thing with the aortic valve, then we'll do it for at least 10 years or until the age of 40, whichever is longer. So usually we'll do it until the age of 40. And more recently, honestly, we do it lifelong. And definitely in endemic areas with some access to care, we advocate for doing lifelong as well. If it's just rheumatic fever with carditis, but the carditis was mild and it resolved, then usually we'll do it around until the age of 21 or 10 years, whichever is longer. And if there's no carditis, then really they only need it for 5 years, but we're in peds, so they end up doing it until about 21 years of age. So where to go from here? So efforts definitely continue for early recognition and treatment of acute rheumatic heart disease, acute rheumatic fever, especially in endemic areas. The WHO and the World Health Federation definitely have advocated for school-based echocardiogram screenings, especially in high prevalence regions. So even things like having access to a handheld echo, because subclinical carditis, so not necessarily, valve regurgitation that you can hear, but you can see on echocardiogram, would merit treatment as well. Um, Definitely adhering to secondary prophylaxis and improved access to care. Um, It'll again be interesting to see how vaccine development against group A strep, if that does come to fruition, how that'll affect this. And then there are ongoing genetic studies in terms of which hosts are more susceptible to getting acute rheumatic fever to begin with. I didn't really touch on that, but definitely we've seen in hosts, especially from twin studies, that there is some sort of genetic component that we haven't really quite figured out just yet. And these are my references, and I'll pass it on to Jen.
Hi, I'm Jennifer Weiss. I'm one of the pediatric rheumatologists here at Hackensack, and today I'm going to talk about post-strep reactive arthritis.
Jen?
Dr. Weiss, we lost your slides. I think they're minimized.
Oh. Okay, they're minimized. Share. Let's see. All right, let me stop sharing for a second.
If you'd like, I could pull them up for you.
Okay, you can pull them up. Okay, you can go to the next one, please. Next slide. Okay, so, oh, no, sorry, back one. Yeah, thanks. Okay, so you may be wondering why a rheumatologist was asked to speak about group A strep, and I just wanted to point out that there are several immune-mediated diseases that we see as rheumatologists. We've talked about acute rheumatic fever, and I'm going to talk about post-strep reactive arthritis, but we'll often be asked to see patients with IgA-associated vasculitis, formerly known as HSP, that can be triggered by recurrent strep infection, as well as patients who present with erythema nodosum or uveitis triggered by strep. Next slide, please. So I wanted to start by giving you the definition of reactive arthritis. So that is an arthritis which develops after or during an infection elsewhere in the body, but in which the microorganisms cannot be recovered from the joint. So you're not going to pull the bacteria from the joint like you would in a case of septic arthritis. And reactive arthritis usually follows GI or urogenital pathogens, things like chlamydia, Yersinia, Salmonella, Shigella. They can all trigger a reactive arthritis. These patients usually present with the arthritis about 4 weeks after the initial infection. It could be a monoarticular or an oligoarticular pattern. So when we talk about oligoarticular patterns, it's usually fewer than 5 joints. The lower extremities are usually affected, and sometimes patients can have dactylitis, which is a sausage digit, tenosynovitis, or enthesitis. And enthesitis is inflammation where the tendon inserts onto bone. And you can see in this picture here, those red circles are the tendinous insertions, and they can get inflamed. Patients usually have an acute presentation with their arthritis. Their joints are painful, warm, and they may be red. And this reactive arthritis in general can be associated with the more chronic type of arthritis known as spondyloarthritis. And oftentimes these patients have an HLA-B27 that is positive. Next slide, please. So reactive arthritis after strep infection has been around for a long time. And when I see patients with post-strep reactive arthritis, I usually say it's along the spectrum of acute rheumatic fever, but there are those in the medical community that feel it's an entirely separate entity. And so the jury's still out, and I don't think we're going to answer this question today, but I just wanted to point it out. Next slide. Okay, so reactive arthritis after strep infection. Dr. Chu talked about acute rheumatic fever, and I'm not really going to discuss rheumatic fever except to describe the arthritis, which again is usually acute. It can be seen in up to 70% of patients and usually involves the medium and large joints. You'll often see elbows, wrists, knees, or ankles involved. The joint can be swollen, warm, painful with range of motion, and red. The arthritis is usually described as migratory and transient, and it appears to be additive. So the swelling can come and go in several joints in quick succession. That's why it seems migratory. And the inflamed joint can be active anywhere from 1 day to 1 week. These patients usually have a good response to NSAIDs, used more often than aspirin. We'll use something like ibuprofen or naproxen. And usually within a few days, their arthritis improves. If you don't treat the arthritis, it is self-limited and will usually resolve in about 4 weeks' time. Next slide, please. This is a picture of Jacquard arthropathy. This is a rare complication that can be seen in patients who get recurrent episodes of acute rheumatic fever. It can also be seen in lupus. It is a non-erosive deforming arthritis, so patients can get swan neck deformities. You can see their distal interphalangeal joint is bent. It looks like a swan's neck. And it's probably easier to see on the x-ray the ulnar deviation of their metacarpal phalangeal joints. Next slide, please. Okay, and this is post-strep reactive arthritis. So this diagnosis is made in patients who develop arthritis following strep infection, but do not meet the Jones criteria. The incidence is approximately 1 to 2 cases per 100,000 children. There's a bimodal distribution. Kids usually present between the ages of 8 and 14, and then it can be found in young adults anywhere from age 21 to 37 years. The male to female ratio is equal. Kids typically will present with pharyngitis, a low-grade fever, and then they can have arthritis and arthralgia. Compared to acute rheumatic fever, the inflammatory markers are elevated, but moderately. They're not quite as high. In acute rheumatic fever, the SID rate could go up to 100. It's usually above 60. It's usually less than 60 in the post-strep reactive arthritis patients. These kids develop their arthritis sooner, so usually within 7 to 10 days. It is not migratory, so it's additive and persistent. It can affect large and small joints, as well as the axial skeleton. And they too can get tenosynovitis and enthesitis. And they generally do not respond as well to NSAIDs, and we'll talk about that a little bit more at the end of this talk. I put up 2 pictures here. You can see the patient in the top picture has a swollen right knee. You can see there's a large effusion there. And in the picture below is a patient who has arthritis and some redness of the joint. And in the ultrasound picture to the far right, you can see there are signs of active inflammation. Next slide, please. I just wanted to show you what a synovial joint looks like. We're not talking about osteoarthritis today, but you could see on the right-hand side, you see the bone and you see the nice thin, or not thin, but normal sized cartilage, the synovial membrane, and the synovial fluid. And then if you look to the picture on the right, it's inflamed, that joint, and the cartilage is starting to deteriorate here. That's not what we would see so early on in a post-strep reactive arthritis, but you can see how the cartilage can be affected. The synovial membrane becomes inflamed, the joint capsule is thickened. And so this is what might happen in a patient with acute arthritis. Next slide. I threw up the classification criteria for post-strep reactive arthritis. It was first described in 1959 by Friedberg. He described a non-deforming febrile polyarthritis without associated carditis, triggered by strep infection, and with a good response to salicylate therapy. We know that this good response to salicylate therapy isn't quite accurate, and in 1993, the criteria were revised to include onset within 10 days of group A strep infection and a poor response to aspirin. And then in 2002, the last time they were revised, the definition was to include acute and persistent non-migratory arthritis. They described the arthritis as additive in 1 or more joints with evidence of prior strep infection and not meeting the revised Jones criteria for acute rheumatic fever. Next slide, please. So how do we make the diagnosis? So we talked about how patients get diagnosed with strep throat. They could have a positive throat culture, rapid antigen test. We could also check the streptococcal antibody titers. Those include the antistreptolysin O or anti-deoxyribonuclease B antibody. And you can compare the acute and convalescent titers, or you could look at the results against a reference range of the upper limit of normal. If you are going to check titers over time, you're going to check the first sample when the patient presents acutely, and then at least 2 weeks later, you'll check a convalescent sample, and you can see that the titer will change if it was an acute infection. So that's really considered the best evidence of preceding strep throat. For ASO, which I would say we use most commonly in practice, you usually will see the antibody response about 3 to 5 weeks after the pharyngitis. So that can be during the first to third week of rheumatic fever when the anti-DNSB titer, sorry, I said that incorrectly. So you see the ASO titer peak sooner than you will the anti-DNSB titer. And then over the next several months, the antibody titers will start to fall off. In addition to looking for evidence of strep, we'll send ESR and TRP to look at the level of systemic inflammation. And then we refer patients for cardiac evaluation, for echocardiogram and EKG. Next slide, please. So when preparing for this talk, I also found this equation. I have to say I've never used it in practice, but this equation was published by Barish in 2008, and it's a mathematical formula that can be used to differentiate acute rheumatic fever from post-strep reactive arthritis. Next slide, please. So why do we get post-strep reactive arthritis? Well, there is a hypothesis. The group A strep has a hyaluronic acid capsule, and that's what helps it evade our immune system. But we do develop antibodies to the M protein, and those work to protect us. But they can also cross-react with certain proteins in our body. So it has been shown that these autoreactive antibodies can bind to cardiac myosin, skeletal myosin, tropomyosin, keratin, vimentin, and laminin, and some of these are integral parts of the joint synovium. In addition, anti-streptococcal antibodies can form immune complexes which bind to the synovial membrane or collagen in the joints, activating the inflammatory cascade and leading to tissue inflammation. Next slide, please. So how do we treat the patient? So as both of the other speakers have discussed, patients are going to be treated with antibiotics. Patients with post-strep reactive arthritis, if they do not develop carditis or chorea, will stay on prophylaxis for at least 1 year, and IM benzathine penicillin every 28 days is recommended. We usually use ibuprofen or NSAIDs in patients, and we'll give them a few weeks to see if their arthritis responds. If not, our next recommendation, similarly to how we treat patients with juvenile arthritis, would be an intra-articular corticosteroid injection. That can be done right here in the office with a little bit of numbing cream. It takes a few minutes, and patients usually have an excellent response. Within a few days, they should notice some improvement in their symptoms. If they fail to respond to a steroid injection or the family does not want to go that route, we can offer a disease-modifying agent such as weekly methotrexate. Methotrexate, though, does require blood test monitoring, so you're not really avoiding any needle sticks if you choose the methotrexate over the joint injection. And if patients don't respond, we could go on to use a biologic medications. First line is usually TNF inhibitors such as etanercept or adalimumab, and there's also IL-6 inhibitors such as tocilizumab. Next slide, please. This was one study that was published a while ago, back in 2009, that demonstrated that there was no increased risk of valvular heart disease in adults with post-strep reactive arthritis. There were 75 patients with post-strep arthritis included in the study. and there's a control group at a ratio of 1 to 2, and they followed these patients with transthoracic echoes over 9 years, and they saw no different in echocardiograms at the 9-year mark. And so they felt that long-term prophylaxis was not needed in patients with post-strep reactive arthritis. Next slide, please. This table just might be easier to see side by side, shows a comparison of acute rheumatic fever and post-strep reactive arthritis. So to summarize, with regards to antibiotic prophylaxis for acute rheumatic fever, it's at least 10 years, but maybe lifelong. Post-strep reactive arthritis patients need it for about 1 year. The carditis in acute rheumatic fever is part of the Major Jones criteria, and 50 to 60% of patients are affected, much less common in patients with post-strep reactive arthritis. The arthritis in ARF is usually migratory and transient and primarily affects the large joints, whereas in post-strep reactive arthritis, it's additive and persistent. It could affect large joints, small joints, and the axial skeleton. The acute rheumatic fever patients have a dramatic response to NSAIDs, whereas those with post-strep reactive arthritis don't. The arthritis usually presents 10 to 28 days in patients with acute rheumatic fever, where in post-strep reactive arthritis, it presents 7 to 10 days after infection. Acute rheumatic fever has a typical age presentation of 5 to 15 years. There's a bimodal distribution in post-strep reactive arthritis. It could be anywhere from 8 to 14 years, and then again at 21 to 37 years. Next slide, please. So this has also been discussed a little bit earlier, but some pitfalls in diagnosis, including patients who are chronically colonized with strep. It may be difficult to recover the bacterium if the throat does not necessarily indicate acute infection. The group A strep, if treated, may also not be found when they go to do a rapid or a throat culture on the patient. And depending on the timing of strep infections, there may also be difficult to use the serologic evidence of recent strep infection. And next slide, please. Oh, this is my references. And if you have any questions, please don't hesitate to reach out. And then I think on the next slide is the QR code for the survey. Thank you.
Looks like there's one question in the chat, in the Q&A. It says, as a takeaway, when should clinical presentation of strep be of concern and be referred for further review? I assume we're talking about acute streptococcal infection. So Sejal, I think this one is yours.
I guess I just want some clarification. Are they talking about like strep pharyngitis, or are they talking about like concern for a more invasive infection? Like
Can you
I
speak
think
to you?
Perhaps speak to both.
So I would only really refer kids for strep pharyngitis, like if they were getting to the point where they were about to get a tonsillectomy. I feel like our ENT doctors always refer to us first. And so that would be like a good practice, just refer them before they need surgery. Because we can always talk to see if they're carriers, we can discuss the treatments for carriers, and then if that doesn't work, then, they can go on to get tonsillectomy. But if it's routine, like, they get 2 or 3 strep infections in a year, I would just treat them and, not need to refer. For invasive infection, obviously those kids are going to be a lot more toxic looking. But if you have a patient who, you feel may have strep, or even like you tested them in your office and they tested positive for strep and days go by, they continue to have fevers, and now like, you know, they're complaining of pain in one of their extremities, or just something doesn't feel right, that's when I would refer them to the ER, just so that we can obviously check their labs to make sure that their liver function, their kidney function, and all that looks fine, because those kids can get sick very fast, especially the ones that already have the erythroderma rash. Like that progresses over a couple hours. And so like sometimes I've seen patients in the ER, and like, you know, attending in the ER will have seen them and the redness wasn't there. And when I go to see them, the redness is suddenly halfway through their body. So anyone that looks like a little toxic and you're a little bit concerned and wondering like what their labs look like, those are the patients that I would refer to the ER.
There are two questions. One is about pandas. The other one is about treating incidentally found high ASO titer with no history of symptomatic strep. And do you always treat it? So since Sejal's already going, maybe you can answer that one.
What is the question about pandas?
Do you want to answer that one too? Are there any labs that can be helpful in diagnosis for pandas?
I mean, I think with pandas to really support the diagnosis, you do have to have some kind of support of a past strep infection. So throat cultures, rapid strep tests, ASO, anti-DNASB, I think that is helpful. But I am also not the physicians that are treating pandas patients, so I can't really answer too much about that because we're not the ones that routinely see these patients. But I think in order to actually say that it is a pandas, you have to have strep in the recent past. And then so an ASO alone without any history of symptomatic strep, like I don't know that I would necessarily treat those patients. I don't know if Jen or Monica feels any differently. But you know, you may see that, and if the patient hasn't had strep and they are clinically fine and haven't developed any other signs of any post strep complications, I wouldn't treat just based on blood work.
Yeah, I might do a strep, like a throat culture, you know, if they're complaining to see if they have acute strep infection, or, but I wouldn't just necessarily treat the high ASO.
Do you want to, Jennifer, do you want to answer about your analysis needed to be monitored for possible kidney involvement, or?
I don't monitor, I don't do a UA for, you mean if I'm concerned that there's a post strep glomerulonephritis? I I guess the UAs would be monitored, but otherwise I don't think the urine tests are monitored. Sometimes we'll monitor urines in patients on long-term NSAIDs, but otherwise not because of the strep infection.
I could take the next one. So there is no group A strep that is resistant to penicillins at this time. So if you have a patient who has recurrent strep a couple weeks later, I would retreat again with amoxicillin. There's really no need to switch the antibiotics. The only time you would consider switching is if you feel like this patient may be a strep carrier, in which case you would then want to switch to augmentin or clindamycin, which are the recommended antibiotics when you're trying to treat the infection and get rid of the carrier state.
1 minute left for the last question for our rheumatologist.
I would say call us if you're concerned. If you think the patient has arthritis, we will get that patient in. We see patients in Hackensack, in Edison, at JFK, and also down at Jersey Shore. So we would definitely get your patient in and we can do a full assessment. And then if NSAIDs are needed, we can dose it. For ibuprofen, I usually do 40 mg per kg divided TID. But we can use longer acting ones too, depending on the patient's age and if they need liquid or tablets. So definitely reach out to us if you have any concerns or questions.
Yeah, especially if there's rheumatic fever, potential for rheumatic fever. Patients with rheumatic fever, their arthritis will disappear with NSAID therapy. So we do want to see these patients before you start treatment, if possible, if that is what is suspected. Well, thanks, everyone. We enjoyed everyone's presentations, and hopefully we will see you at the next one coming up. Thank you all for attending. Somebody wants the presentation to be shared so that they can share it with their teammates. So I will leave that up to Sarah and the administrators here.
Yep, we'll send out the recording in the follow-up emails. Thank you.
Thank you all. Have a good day.